All right, thanks everyone for having me. So Isaac Marshall, I'm one of the paediatricians that works in Geelong. I've been here for about 11 years. It's my second time back to the conference. It was fantastic the first time around, although we were sitting in little huddles around a computer. Now only half of us are in the huddle and the computer, and the rest of us are around sharing coffee smells together. So fantastic, and the wonderful thing for me is most of my life is meeting people at the end of telephones or at the end of referral letters that I have to unfortunately decline back. So it's terrific to put some names and faces together. From the paediatric side, it's such a pity actually, you should all be next door listening to Kathleen, because she's fantastic. But thank you very much for staying local. And I was asked to speak, or we were asked to speak on paediatric red flags. And I've taken a little bit of a variation on that and said that one of the difficulties in paediatrics is that as one of the little subspecialty areas, it's so hard to know that when something's unusual, we can identify it as unusual, but should I be worried that this is a red flag, or is this actually just a green flag I haven't come across before? So basically the idea of today was just to whip through a whole lot of little bite-sized topics. So I am with the new fad. I'm an ADHD sort, and so we work better in tiny little fragments. We'll see how many we can get through. The disclaimers, I don't have any conflicts of interest. Any photos that you see of babies and children are from Google search engine stock, and therefore I assume consent, and every other figure has been credited. I would also share my acknowledgement of country that started the conference today. The only other disclaimer is that I possibly have overused the PowerPoint designer tool because I prepared this late at night. And the last thing, just before we dive into some nitty-gritty, is I like to now, when I get to present across craft groups, just highlight this idea. People may have come across, people may not have come across. If you haven't, please go and read into it. It's fantastically interesting, of transactive memory. And medicine is just the definition in terms of professional transactive memory. What do you reckon I hit? Just green and back? It's quite intuitive, good design. So transactive memory, in a loose way that I grab it, is when you have a body of people and everyone grabs a little bit of knowledge and they're responsible for remembering that. So this happens a lot in family groups, in couple groups. This is a couple that one has always remembered to put the bins out on Monday night, although that's never been officially put out there, and the other one always remembers when to pick up the kids at Thursday at 5 p.m, though that's never explicitly been said. And you take one member of that partnership out and suddenly there's this whole gulf of knowledge that happens. So it's a wonderful thing that we've adapted as a species, but this is what we do as a profession. And so I think it's always a great honour, but I always like to open up with this, is that I have this privilege of spending my time in a tiny little rabbit hole with small children up to the age of 18, still small, and therefore I can let the synapses for another whole lot of learning let go, but I rely on other experts in my profession to go to that. So I certainly hope today is not about teaching people how to suck eggs, but it's just a few sort of insights from my tiny little rabbit hole. Okay, diving in. First of all, these are all come from telephone consults that I've had on ward service in the last 3 or 4 times I've done service. So I've just plucked down and written down the topics as soon as this came up and said these are all people that are professionals seeing a lot of children and they're worried that they're seeing a red flag. So is it okay that this little baby I'm seeing is still jaundiced? So this is not going to be a thorough topic of anything, but just some initial thoughts. How persistent does jaundice have to be worried that it's persistent neonatal jaundice? So if we go to the textbooks, they say something like 14 to 21 days. But I'm pretty sure a lot of people in this room, like me, see a lot of yellow babies that seem to extend a little bit beyond that, and they otherwise seem to be pretty okay. So when do you actually start worrying? When do you start chasing the needle in the haystack? And especially the most common thing that we blame for jaundice lingering around is breast milk jaundice. So if you're breastfeeding, you can be jaundiced well up to your 6-week check when you guys are immunising and checking the hips and hearts again. And nearly all of these we know are the benign unconjugated form. So I think key questions just to ask yourself, is this just a green flag I'm looking at, or is there something red in this flag I should be worried about? First of all, the first 2 questions are very generic to paediatrics. What's the rest of the baby doing around its liver? So is this actually a baby that my first gut feel is a little bit worried, or does this baby look very well? And one of the best ways to tell if a baby's doing all right is it putting on weight? So what's the weight gain? A bit more pointed question to the jaundice question that's always worth asking, because you won't get that necessarily volunteered, is what colour's the baby's poo? And we'll come back to that, but paediatricians seem obsessed with poos and wees, but there are lots of externalising signs in poos and wees. And just a very outside chance, but do they remember actually having the newborn heel prick test? So we have some early discharge, a lot of early discharge that happens just to survive in the maternity side. We don't expect to miss any, but we know there's up to like 25 metabolic diseases that get covered on that. So for some reason that's been oversight. It's a very quick question to ask. What might you order? So this is always a question of, and it's really about am I at the first line investigation stage? Am I at second line? How worried am I about different things? So it's definitely worth doing a full panel of liver function tests, so not just the bilirubin. And if they haven't given you a split bilirubin, so a conjugated versus unconjugated, you do want that. And we'll come back to why that's particularly important. Very common cause is some hemolysis, and it's just worth knowing if there's hemolysis happening. If you're seeing this baby a few weeks down the track, you would presume it's a very slow hemolytic process, so it's not going to be acutely threatening. But it does let you know that there's actually something that's contributing to this baby having more jaundice. So a direct Coombs test or a direct agglutination test and an FBE just gives you a baseline hemoglobin that it hasn't gone too far. We do consider as second line, so if you're seeing this baby a few weeks down the track, the TFTs are partly covered by the heel prick, but not completely. So it's worth doing another set of TFTs, but that's very rare for hypothyroidism to present like this. And G6PD is very rare as well, but again, it's an easy test. And then UTIs hide everywhere. So it's worth trying to catch a urine, easier for you to order than for the parents to achieve, but you can let them go in 10 minutes. When do you phone a friend? Or when might you phone a friend? If you're not sure, so this is when I like to have a chat over with my colleagues in primary care. If you're not sure whether there's sufficient weight gain, you wish you went to Kathleen's talk and not mine. If you're not sure what to make of the LFTs, so LFTs at this age are really difficult to interpret in a way. Some go up, some go down, different combinations. But especially if there's something weird and wonderful like a hepatitis that you're not quite sure of. And if you're not sure where it looks like there's a Freudian slip being late at night, but the conjugated portion of the SPR. So that's particularly one of the things to keep in mind. So insider knowledge from my rabbit hole, I reckon jaundice hangs around, and especially the well baby who's breastfeeding, hangs around a lot longer than textbooks suggest. We can detect a yellow tinge to the skin or in the sclera at an SPR of 70 or 80, which is very low. And usually that's on the way down. Of course, you don't know what the number is when you're seeing them in the consult room, but it's usually on the way down. So it can linger around for a few months. So generally, in terms of how often you do tests, if it's downtrending, I think you can pull out. So if this is a well baby and that SPR has clearly dropped across a couple of tests and you know you're on the way down, you don't need to keep following it down to the normal range. What I keep alluding back to is this colour of the poo, which is terribly interesting, and we have had at least 3 cases in the 10 years I've been here, is this weird and wonderful condition called biliary atresia, which is when the biliary tree gives up, and so you lose pigmentation, and that's a very distinctive sort of presentation. So you'll be lucky if the baby poos in front of you, but if the parents show you a photo and you're not convinced there's enough pigmentation, that's definitely phone a friend situation. So we, in paediatrics, you get all this wonderful talks about changes in poo colour from green to yellow and etc. We don't care about that whole spectrum. We just don't want to see something kill the colours. So we don't like white poos, we don't like black poos, and we don't like red poos. All right. All the other colours, the hawthorn, they're fine. Right. And then the last thing is this kind of ALP is just thrown in babies to confuse you, and it's really hard to know what to make of. So as far as I can see, ALP just does its own thing in babies, and if it's doing its own thing in isolation and everything else is settled, that's usually okay. And we know that there's a sort of biochemical phenomenon that you can have a huge ALP, even extending up to 12 months of life and beyond, that can get up to hundreds and thousands. If it's just in isolation, it's usually not a problem, and that's a transient phenomenon that's well defined. I've been asked to leave questions to the end, but store any of the questions in particular that you want to come back to. The next couple little segments are about this tricky little thing called fontanelles. So we get a fontanelle question every day. So the next two are if the fontanelle's too small, if the fontanelle's too big. So where's that fontanelle gone? Just to remind you, this is what a baby's head looks like if it looks like mine. So if you take away all the head, it's got lots of little joining bits of the little continents of bones so they can still grow. And the way I look at the fontanelle is just, it's the absence of a suture, right? The sutures is what we're all worried about medically, and we want to see that they're remaining open and patent so that that brain can grow underneath but still have a bony cover. And the fontanelle is just where the suture isn't. The problem, of course, with a fontanelle is if you can't feel it, it may still be there, it's just you can't feel it. And so we're trying to guess in the consult room how worried to be. And so the key questions I think to ask yourself and the family are, what's the head circumference now? And where's the head circumference been? And so that everything about paediatrics is watching trends and watching trends. And if you've got a reassuring head circumference now, and it has been reassuring, so it's following centiles, the fact that you can't really feel a fontanelle is much less worrying, okay? But the third bit's this a little bit about what's the cranial shape actually doing, all right? And we'll talk about some wonky head shapes because babies come in all sorts of wonky head shapes that don't look anything like the Kleenex ads. And when do you worry about that or not? So that's actually documenting that in your notes, that when you see this baby, this is what the head looks roughly like I would expect a normal cranium to do, or is it doing something very wonky? Phone a friend, so get on the phone to myself or one of my colleagues if you're not sure you're getting a green light on those. So you worry about the head circumference, you worry about the trajectory of the head circumference, or you're worried that you've got a misshapen cranium. What can you order? So we'll say this area is not terribly rewarding in terms of investigations. So you can order a skull x-ray to see if the sutures are open, but you can be tricked. And again, you can do a targeted ultrasound to see if the sutures are open, but then you've got to tell the sonographer where you're targeting. And CT give all answers, but also radiate your baby, all right? So we're trying to be sparing with those. So actually the main thing is, this is a very clinical picture. This is keep them on your books, get them back in a certain interval, see what's happening with the head circumference, see what's happening with the head shape, reassuring the parents that everything's going normal. So in terms of the rabbit hole knowledge, the fontanelle only has to be open to serve its purpose. It doesn't have to be big or small. And that when there's a mismatch between just how big your fingertip tends to be and how big the fontanelle is, it means clinically that you can't rule out a closed fontanelle, but you look for those other clues. And the likelihood is it's still there. What about if it's massive? All right, so you're just feeling, and all you can feel is softness, and you can't really feel the bone. And again, is this something I should worry about with this baby? And the questions are very similar for the first two. What's the head circumference now? And what's it doing? What's its pattern? All right, and is it following a centile, or is it, particularly in the case of a big fontanelle, is it starting to shoot off? So we're crossing up centiles and shooting beyond where it should be. But the third question is, what are the parents' head circumferences? I'm pretty sure if I did a straw poll who has ever thrown a head circumference tape around an adult, it'd be pretty small numbers. And unless you're like me and you're bald at the age of 30, and so you know what size your hat size is, the best clue you have is asking parents, have you always struggled to get big hats and stuff like that? And often one of them will dob the other one and say, oh, they've always got a big head, etc. But this is really common cause, okay, for seeing a little baby. It's the first question. It's the way we've first diagnosed familial macrocephaly, is to see a little baby who's doing exactly what mum and dad did, right? And that was grow a big head. It's just they really stand out in babies because they're all head. So again, phone a friend if you're worried about any of those. So you're worried about the head circumference, you're worried about where it's going or where it's been. And if you can't convince yourself this is a familial trend and you just want to bounce it off us. The big, this situation, I would go straight to a cranial ultrasound. And what you're looking for in a cranial ultrasound, fortunately at this age, if you get in early, it's a non-invasive test, it's not painful for baby. They've got a nice big sonographic window without bone. And you're really looking for hydrocephalus, okay? So a lot of the mischief that's going to cause a head that's growing too big and hydrocephalus in little babies will present with swelling in the CSF. And we can document that really easy. And then it's next stage about finding out what's gone wrong with the plumbing, what could be blocking that plumbing, which is a little bit beyond where I think we need to go to today. So insider knowledge, it's all about the trend in the head circumference growth. Familial macrocephaly must be out there because it's defined by statistics. So a portion of the babies and the families that you see will have big heads. And a big head that's following the centile is usually okay. So when I say following, the big probably clue here is parallel, all right? If it's making its own curve that's running parallel to all the other curves, so you're just adding an extra 99th centile, that's usually okay. And the tricky ones for us medically are either the ones that started at the 50th centile and are crossing up in front of you. Are they just going to family, right? Are they going to even out on the 95th centile or the 99th and start curling? Or are they going to keep heading up in an upward trajectory and shoot off? So it's all about having heaps of data points and plotting, which is why, again, it's about just seeing these babies serially. If you're worried, to be honest, I'd jump in a little bit quicker with these guys because I think cranial ultrasound's a very quick study. You can even have a cranky baby that's moving around. You just need a window and a few shots to capture that CSF space. And then everyone would be happy to sit on it. If you've already seen the curve, then you don't need the ultrasound so urgently. So if you've seen them starting to curve around and following the centile curve. But some families will be big. And then the last thing with little baby's head is you're worried about the shape of the baby's head. And just to flag, this is one of the scourges or one of the new things that you've all seen because we throw all our babies on their backs for 6 months with SIDS guidelines, and it's very hard for a baby to sit straight back. So most of them will pick a side, right? And they've usually picked the side in utero, I believe. So you'll see some babies that straight away in the first couple of days of life always like to flop to one side. So the brain's wanting to grow 24 hours a day, the baby's wanting to sleep 18 hours a day. If it flops to one side, it's easier for the bones on the other side to expand back out. And so you get this phenomenal positional plagioccephaly. And you'll get worried parents that come in and say, my baby's head's all wonky. And I think the key question for us is everything getting pushed in the direction I would expect for a baby that's flopping always to this side? So you actually want a wonkier baby, right? If you look where the ears are, you want one of the ears anterior to the other one. And the forehead, you want some frontal bossing on one side versus the other. That's actually reassuring for ruling out what we would prefer not to see, which is a suture that is closed, so a craniosynostosis. So this is one of the things it depends on your relationship with the parents, but say a wonky baby is a good baby at this stage and it will all even out, okay? What we don't want to see is one of these variations. So we like the normal, of course, but what we're worried about is a baby's cranium that's not a normal shape, okay? So if you see any of these, it doesn't look like that you're just pushing from one direction because the shape doesn't correspond to that. And one tip from someone that looks at a lot of babies like this, get your fingers out, throw them in each ear and look from above. And that's one way to tell whether you've got any anterior or posterior to the other. Okay. So is everything moving in the direction I expect to move? And then just another thing is, of course, is there any concerns about the gross motor development? So positional plagioccephaly, extremely common, but is there something about this baby that's actually, this baby's not moving normally and I'm dealing with something else that's actually, apart from it just opting to choose to lie to that side? So usually you don't order anything apart from another review with yourself. Again, it's just trends, so the head circumference is reassuring. The actual positional plagioccephaly will not resolve quickly. And so when I say not quickly, you're looking at 3 or 4 years until everything will even back. So one of the things that's out there is these helmets. And you'll get parents turn up and say, should I throw my baby in a helmet? The evidence is really controversial even in paediatrics because essentially what it looks like helmets do is get everything back to normal-ish quicker. But if you see kids in a clinic that had plagioccephaly so positional plagioccephaly at 3 to 4 years and the assessors are blinded, we can't tell who had helmets or who didn't. All right, so it just gets things back quicker. So the RCH clinicals definitely at Plagia Keighley will still give away helmets. And then when we go to the conferences, they tell us not to use helmets. So it's all a bit confusing, but that's what I sort of say with parents. It's reassuring. You've got to allow it a bit longer, so it's not going to go away in 12 months. As parents, you'll always notice things are slightly off because that's what parents are for. They notice the asymmetry in the face. None of us are perfectly symmetrical. But once they've grown hair, and again, without going bald at the age of 30, no one else will notice, right? And then this was very reassuring that one conference I went to and a neurosurgeon spoke up and said, really, he was, very cautious about actually even of those investigations, the x-rays, the ultrasounds, CT. And he said, basically what I'm deciding to operate on is what this is clinically. And his choices are craniotomy or nothing. Isn't it a wonderful world to be a surgeon? Bang or nothing. So he just keeps seeing these babies serially because basically what you're doing is making a decision of whether I need to go in and split bone or not. All right. Moving a little bit further down to eyes, okay, and this one's a bit quicker. Basically, baby's eyes in the first 6 months all over the shop. So not too much of a worry usually about strabismus and squint. Beyond 6 months, yes, we have to worry and we have to start doing something. How do we break that down? Basically, as far as I can see, eyes, I said eye alignment is basically a microcosm of evolution. So this is our, almost a triangle of needs. First of all, we need to feed. So all babies are wonkies. They're focused on nipples, bottles, teats. And then they start thinking about who's actually providing the nipple or bottle or teat. So they look on the face. And then they start getting interested in the wider context slowly out from there. So it takes about 6 months really to guarantee binocular alignment for babies. Some babies get there quicker, some don't. So you'll notice some of these babies that are doing wonky things. And so the key questions for us in the family, how old's this baby, first 6 months versus after 6 months? Are you able to see that both eyes are actually moving? So is this non-paralytic? So you do want to convince yourself that medically, and we don't want to miss a palsy or an ocular muscle that's not working, even if they're not lining up yet. Is this baby able to look at you or at least fixate you with each eye? So it's very hard to determine visual acuity in these tiny little babies, but most babies will want to fixate on someone they think might give them a feed or take their feed away from them. So if you get the parent to cover the eye, and do they appear to be looking at you? What's the head circumference? So is there one of these rare zebras in there that's a big lump that's presenting as a non-localizing lesion and taking out your sixth nerve? Extremely rare. And the last one I've just put is there torticollis? And again, this is another left field thing, but rarely we see babies actually tilting their head and maintaining what looks like a congenital torticollis because they've got a fourth nerve palsy, and that's the way they get their vision lined up. Again, those last two ones, extremely rare. Okay. So again, usually you don't do anything and just watch at 6 months if you can convince yourself that you don't have any paralysis on any of the eyes. You can consider a cranial ultrasound if you're worried that the head circumference is starting to balloon up. After 6 months, I automatically get ophthalmology involved, and they need to watch things to make sure that there's no amblyopia develops. And so the main problem with strabismus or a squint after 6 months is that the brain will choose a winner and start investing in the eye that seems to be doing the better job and forget about the other eye. And one of the devastating things on a worldwide perspective is when you see these kids 3 or 4 years and nothing's ever been done to kind of test out the weak eye. So the brain's just given up on that eye and they've got a very severe strabismus and they've got unilateral vision. So what the ophthalmologist will do fancy tricks about making the weak eye do more of the job. And that consists of things like patching or putting atropine drops in, stuff like that, if you've come across patients like that. Another thing in terms of development, a very common one, a very common presentation for all of us. Should I be worried that my child or this child isn't walking? So the textbook says that 12 months for the first steps. But we all know that this is an average and it has a very wide confidence interval, and it makes it hard to know when to mobilise further investigations or further intervention, or is this just something to watch? So your key questions, how old is this child? And we'll come back to, everyone's going to have a different threshold to when to worry. I think it's very important to decide, is this a delay? So is this baby or this child getting through things but just doing it at its own steady pace? So someone has to be slower and someone has to be higher, except for Deakin University students, where we rate all of them as 75% above average. So is this an isolated gross motor thing, or is actually the baby starting, like the most obvious thing really for little babies is gross motor, but when you start prying into things, is this actually a little bit more universal? Is this baby reassuring you on the fine motor? Is it doing what it's meant to do with speech and language? Is it fixating on you socially? Or is it just that the parents have noticed because everyone's watching in playgroup about the walking and actually there's other things that you're worried about? Is it a boy or a girl? We worry about boys because of Duchenne's muscular dystrophy, even at this early age. And the last question is there any way that you can coax this child, or even the parent, to let this child do what it wants in your rooms with your 10 or 15 minutes you have? So you have to convince them you vacuum the floor and it's clean and that they're allowed to jump around. But it's amazing what kids will do for you without, you looking and the parents looking and they're not holding the kid, and if you can actually reassure yourself they're pulling up onto furniture and they're starting to cruise along, you're getting a wealth of information about the underlying neuromuscular strength and coordination, and you're going to feel a little bit more reassured. Of course, if they don't play ball and they're really scared and they're going to stay with parents, that makes the assessment a little bit harder. Only one investigation I'd think about is the CK, and it's an easy enough test to do, and again that's just looking for the poor person in this room that spots the Duchenne's muscular dystrophy. The radiology I put in there is that unfortunately very infrequent, but we have had cases of NAI that have presented, and the reason the child is delayed walking is because there's underlying untreated fractures. And they've only come up as callus when we've been looking for other reasons. Again, without going to NAI, very hard, just yet, it's very hard to pick, but just to consider. So really the CK is the main thing I'd be worried about, especially for the boys.
Family violence, when you say NAI.
Family violence.
Non-accidental.
Sorry, and I'm using an acronym, but non-accidental injury or family violence. So an injury to the child that we don't believe is an accident. So when would I phone a friend, or when would it be good to hear from you from a paediatric point of view? My cut-off's 18 months. So that's a pretty wide confident interval, but if this child's not walking by 18 months, there's something we definitely need to investigate. People have different thresholds, so that's not a hard and fast, and some people get worried more, but definitely if you're looking at a normal distribution, that's something abnormal. If you're worried that there's a more generalised developmental delay, worth getting peds involved. If the CK is not totally negative and not reassuring, and they don't have influenza A giving them myositis, and if you're concerned about family violence or non-accidental injury. And then a couple of insider knowledges. Just one thing that's come up that tricks us is this Gowers sign that we learn about, which is kind of peeling up from the prone position and kind of walking yourself up your legs in order to stand up. That's a normal thing in development. And what's normal, though, about development is to not have to do that forever. So if you've got a 12-month or a 15-month or a 2 years doing that, that's not yet in isolation what I'd consider a Gowers sign, but certainly beyond a 3-year-old, no 3-year-olds are sort of using that mechanism unless they've got proximal muscle weakness and they're having to compensate. So in terms of flags that look red, it's not too worrying when they're younger. And then the other thing to reassure parents is bum scooters tend to be often late to get up. So it just seems like bum scooting is a very efficient way to get around, and you always kind of, one day I'll ask an 18-monther why they want to get up and walk, but it tends to be something about pace of getting where you want to and trying to relieve the pain on your knees. And it seems like bum scooting gets around those two things, so they're quite happy to stick with it for a while. All right, so we're gradually getting a little bit older. We've still got a bit of time. We've got about 13 minutes. So these celiac tests are positive, and celiac disease is just there to confuse us and humble us constantly, confusing tests. A non-specific disease, even though it sits squarely in the gastro section, and it's meant to be really easy when we talk to the gastroenterologist. So your first thoughts, are these celiac tests positive, are they positive? Right? And there's a lot of confusion out there, but the HLA testing, so the DQ2 and the DQ8 testing that we do, is not really celiac testing. So it's a predisposing test. And the reason, we'll come back to that, and some authorities say still to never use it, and some say always use it. And I think it's just, I think it's a practical test, but you need to know how to use it. So HLA DQ2 or DQ8 captures about 30 to 40% of Anglo-Saxon population. All right, so it's out there. And why it's come up in the celiac chapter is that you need one of those to develop celiac disease. So the gastroenterologists deal with the very, very rare ones, but if they're both negative, almost for all intents and purposes cannot develop celiac disease. All right, so you're thinking about something else. So therefore, I don't think it's a test that's a total waste of time, because if you've got a person that might be lining up to have a test every year, so my type 1 diabetics get a celiac serology screen every year. If I do a DQ2 and a DQ8 on them and they're negative, they actually could probably go without that test. So it's the negative that's useful. The positive is not so useful. So that's the first thing to counsel parents when you're coming back and it comes back and they think they've got celiac disease. And only about 1% of those will go on to have celiac disease. So 99% of those DQ2, DQ8 positives, no celiac disease. The second is to ask yourself, before you order the test on the celiac serology, so the antibodies, do they have any chance of a positive test? And if this family are already excluding gluten, and this child is already excluding gluten, the test will be negative, unless they're not doing a very good job of excluding their gluten. So you need to be on gluten to have a positive celiac test. So a negative test off gluten is, again, not reassuring. It doesn't tell us that we don't have celiac disease. So questions to ask yourself: symptomatic. So symptomatic celiac disease is really easy, but that's not what we're dealing with, because it's really hard and we all see the variations, and often it's asymptomatic until you've tested for why are they iron deficient and you've thrown it in your panel and suddenly they've come back. But the reason I ask that is that a lot of symptoms get blamed on celiac, and it may not be one of the things medically, is to try to differentiate what's actually we can fairly attribute to gluten in terms of our knowledge in 2023 and what we can't. Certainly be much more worried if there's other autoimmune disease either in this individual child or in the family, especially if there's family history of celiac disease. And then this last question, again, it depends on the way you like to practice and pretty much the risk tolerance or investigation tolerance of families. But I have a lot of families that I say, if we go through all the testing and based on what you've seen with your child, and I tell you your child does not have celiac disease, are you going to throw gluten back into their diet? And if the answer is no, we might have the question of like, well, do we go through all that? And it might be another time. The individual child might want to come back later on and reintroduce bread to their diet when they've got control. But if it's not going to change what the family do, you might ask yourself, why go through all the investigations, including a long wait to see a gastro and then to go through a biopsy. So that's why I've said you might order tests if it will change management. And that's just, that again, that's a personal way of practicing and not telling people you have to do it like that. The main two tests are tissue glutaminase, transglutaminase IgA and total IgA, and the deaminated gliadin IgG. And I would recommend people write that out, not just write celiac serology, because there's a whole lot of different ones. So it's worth saying exactly what you want to do. We talked about DQ2 and DQ8, and I'll leave it up to you whether in the individual situation you do that. Make sure the person is on gluten if you want an answer that you can use. How long do they have to? So how long do they have to be on gluten to get a useful test? Really hard to know with the blood tests. So if you send these kids to a gastroenterologist and they're on a gluten-free diet, they'll want them on it for they'll want gluten in the diet for about 6 weeks to get a good biopsy result. So I kind of use about the same rule of thumb, about 4 to 6 weeks on gluten to get a good serological response if they're going to get one. So when to phone a friend? Definitely phone us if there's unambiguous results. This kid's clearly got celiac disease I'm really worried about. As we all know in this room, very difficult to get in a paediatrician, so that's not one for a fax machine. We do want to see this kid and at least get them on to see a gastroenterologist and a dietitian. Especially the conversations we have that are really interesting are the ambiguous results, so they're not all negative, but they're not all positive. I'm not sure what before referral meant to my brain at 11:30. I think it was highlighting that just conscious of the weight and the access. So before actually putting the fax referral, this is one I would look out for at the end of the fax machine to try to get things on and better for this kid. people in the room might be familiar that there was guidelines put out by the European Society in 2020 that allows for non-biopsy diagnosis of celiac disease. And this is essentially if those serological tests are so high that it's very hard to explain them in any other way. Now, the last point in that is that the local paediatric gastroenterologists are still relatively pro-biopsy. And so I'm just pragmatic in the middle and won't look into motivations of that or not, but they will see all the exceptions, and gastroenterologists will see biopsy positive negative serology, and they will see the hugely positive serology which don't have active celiac. So there's definitely an argument for that, but I also have a number of families that have been very comfortable to make lifestyle decisions and dietary decisions, especially because Paco cafes all have gluten-free options now, or wherever you are in your locale. How many more times am I going to hit that? That's going to be the question. Just the middle point. So one thing with the guidelines is that the guidelines are very nice, stepped out, do this test, and if it's positive, come back and do endomysial and come back. And kids don't appreciate lots of tests. So I think we're all a bit pragmatic with that. And again, you don't want to order all these expensive tests as first line, but it, again, depends on your index of worry and how many tests you want to put this poor 5-year-old through. So a lot of us will tend to, do a few. If we get over the speed bump to actually do tests, let's think about what we can do at the same time. Red or green? Should I be worried about this bruise? So this is about as tough as it gets in primary care or frontline or undifferentiated presentation, and you're the first professional meeting these children. How often do we see bruises, and how often do we see family violence or non-accidental injury masquerading as a bruise that's just happened in the schoolyard? And so this is about as hard as clinical decision-making gets, really, I think. The key 5-minute warning. So key questions, people have come across this before. We're asked to explain to come up with a physiological mechanism that would explain the physiological injury that we see in front of us. So does that sound plausible, whatever has been provided to you? So I've said at any stage of development, so if the reason for the injury doesn't make sense at any stage, that's very odd. But the next question with kids is, where's this kid up to developmentally, and does this make sense? So if this is a kid that fell over toddling down stairways and they're 9 months, there's no 9 months toddling down stairways, right? So that's often the key thing we're asking ourselves in a paediatric point of view is, does this make sense? Does the history make sense in terms of this child's development? Has the story changed? Was there a delay in presentation? And this is one I'd say we definitely share the pain on. So I've said there, I'm very happy to take, or any of the paediatricians would be very happy to take a consult about where we go to with medical management. We're all very aware of the duty to report and notify, so that's one aspect. But in terms of where do we go with this child in terms of ensuring their actual physical health and also their safety, share the burden. We want to be on the phone with you and carrying that with you. And especially if you just want another opinion about the alleged mechanism and whether that makes sense. Here's a few red flags really for the very common bruises and when you should be worried about bruises. So we're very worried about a kid that's not mobile, so they're not cruising and they're not up on their feet, and it's pretty hard to get the velocity of injury that's going to cause a significant bruise. Down the bottom, that 10-4 faces, so TEN is the torso, the ears and the neck are all worrying areas, and then the posterior aspects of things are all very hard areas to get bruises on in a young child, relatively speaking. We know things that are over bones will bruise more easily, so if it's not a bony area and sitting in the middle of the abdomen on the torso, what provided sufficient velocity and force of impact to cause that massive injury? If there's any pattern or clustering, so if you're getting multiple bruises in one little suspect area. And 3 minutes. I don't know if we want to get into controversial areas. Who has not heard enough about adolescent eating disorders? Maybe we can come back to that, and I'm going to slide through. But to this question here. The key things on so I flashed through what's medical instability, and that's a big global question. So medical, biological, psychosocial, right? There's a lot of instability that's on the psychosocial side. But if we're going to hone right down onto which of my adolescents in my room are so medically unstable that they cannot safely be in the community and they need to be in a hospital bed, and we hone a lot, apart from leaving the biochemistry and the ECGs aside, we do a lot about cardiovascular stability. And I think the key thing with cardiovascular stability is it's only as good as the assessment. And so this is what I'd really implore people to do. And it takes time, but for the test to be valid, to do a postural tachycardia, or a postural heart rate and a postural blood pressure, you need to have the patient lying down for at least a minute to accommodate, and then you stand them up and wait. So you can keep talking to them, right? Take your history then, but they've got to wait 2 minutes because we expect a postural tachycardia physiologically, as we know. And it's about the persistence of that that's a concern. So you do their heart rate at 2 minutes, and then you do their cuff measurement at 3 minutes. And that's your postural tachy and postural blood pressure to talk to us about. If you're worried about POTS, that means the patient has to stand up for 10 minutes to do a screen. So keep talking to them, even more questions. So this is when to really worry about is when you have a postural tachy of over 30 at 2 minutes. And that may be a problem, but there's lots of statistics, and we argue about this in our paediatric group, let alone wider, about what's actually the normal centiles at this age. So when you go to your slides, I've given a whole lot of evidence, but basically I think the hospital at the moment has a very generous guideline that is probably overlapping significantly with a cohort of people who we never measure their postural tachycardic response until they come in with concerns about their eating. So we don't have their pre-morbid concern. I'm going to flick through that. The last thing in my 1 minute, which has nothing to do with red flags, but if you're going to take away one thing for homework that's changed significantly in the paediatric space in the last 12 months, it's how we manage adolescent asthma. So go and chase up the RCH guideline and actually specifically put in adolescent asthma. The significant change for those that haven't come across is that any of your patients over the age of 12 who has a Ventolin puffer that you believe they still need, so they have asthma, should now be on a combined budesonide and formoterol puffer, and can actually use that both as a reliever and as preventative if you believe them to be on preventative. So essentially no 12-year-olds out there with just a blue puffer. Questions. So I'm very happy to take questions. Sorry, that was speaking very quickly. Thank you very much for sort of appearing to stay tuned in.
Thank you so much. So we've got a couple of minutes, not enough. Has we got a microphone? Yes, Deb.
Thanks, Isaac. When you're monitoring a child's head circumference, what time frame between measurements is appropriate?
Yep, so 2 days seems way too much, way too soon. And so basically the shortest interval in any growth in these little babies is 1 week. And that's the reason, that's probably need more than that for your head circumference. But the more common thing is people worried about weight. And so when they go to my maternal child healthcare nurse, we try to space it out for at least a week, and they'll often do the measurements as well, and they might get 0.5 centimetre difference. So I think it's there's no hard and fast, but I would say a month is probably a long time, so maybe every 2 weeks, but they don't need to see you in your rooms, you just need to get the measurement. So if they're seeing their maternal child healthcare nurse at 2 weekly intervals and you see them, say, at 4 weeks to see actually is the cranial shape all right, I reckon that's enough that the data is far enough away to not get noise, but not so long that you're missing an earlier signal. But there's no evidence for that, but that's just been my hunch.
Thanks. Any more questions? I've got one.
Perhaps just introduce yourself, because it'd be great. I'm still trying to get faces to names. And
Well, you're
thank
very
you.
different.
Oh, no.
I'm Monique, I'm one of the GPs, probably
Hi,
spoken
Monique.
to you a few times. Just wanted to ask for babies that have like vacuum deliveries and cephalohematomas that have settled down but then still have ongoing bony lumps, is that something that settles over months or longer sort of period of time?
Yeah, especially the cephalehematomas, they can stick around for a couple of months and really throw you out. So it's knowing that history and knowing that was there. But yeah, the cephalehematomas is a frustratingly long time for that bone to be resorbed or the blood to be resorbed. So as long as you're aware of that being there. The other, just as a bit of a tangent to what you ask, is that unfortunately contributes to positional plagiocephaly. Can you imagine that side, especially as the cephalhematoma on one side, you see the babies tend to go to the other side. And there's no easy way of sort of coaxing them back because they're still a little bit tender until that hardens off. So I think the answer to your question is just if you've got early documentation that there was a cephalhematoma on that side, if another colleague is seeing that baby 2 months on, they know that there's already a reason to be a little bit bigger and protruding on that side. But yeah, it can be a couple of months.
I think we've got time for one more question. I don't know, is there any more online questions?
There's one online.
So let's take one more on the floor. Yep.
You've been recommending to call a friend. Is there any way of calling the Royal Children's Hospital, especially about NIAs, or do you recommend to just send those children in?
Yeah, so I think the question was to phone a friend or who you consult with, or do you contact your local hospital or the Royal Children's, or do you just send them in? So it probably depends on your locale, and I realise everyone's not 10 minutes down the road from where we are right now. I would, hopefully you've got a local paediatric service, and I would start there even ahead of the RCH for something like family violence or NAI. Mainly because first of all, it's a question of where that, sharing the index of concern and what investigation medically can be done where, just so that we're not throwing everyone up to Parkville. So the most familiar environment I am, having worked in Warrnambool and Geelong, could do a lot of the investigations initially at those local levels and then discuss with the Victorian Forensic Paediatric Medical Service about whether we need anything more. So I would recommend starting with whoever your local paediatric phone to person. So I guess the underlying thing there is it is a phone consultation. So it's an acute on the same day consultation. And then if between you decide this is something that needs to go to RCH or tertiary, absolutely. But I can tell you there's no room at the inn at RCH more often than not. But as with everything, we can get through a lot of the necessary work and inform that the triaging of those referrals at a local level.
Can I say, I don't know whether I ring the hospital and speak to the paediatrician on call, and I found that a fantastic service. I don't know if people know about that, but or you want people to know, but
we get plenty of calls every day. That's right. Very
but
happy.
you're very helpful, and I think with our access issues, sometimes just being able to speak to a paediatrician about your concerns, and you can move on with something. It's been really helpful for me. We might have one question online.
We do. So I'm going to ask questions on behalf of the online audience. There was a question that I think they're asking. What about delayed presentations? So delayed due to rurality, costs, refugees, when there's delay in finding out about missed milestones. Yeah. Do you have any pointers and any ideas for people to catch up on those?
Yeah. So I wonder how to interpret that question. So I can take it in, are we worried specifically about the branch of delayed presentation with what should be of medical concern, and are we worried about a level of neglect, or are we worried about delayed and we're catching because of delayed access?
I think it's an access question, which is tricky because we've got people in different regions.
Yes,
so if you can answer not specifically around certain clinics, but...
I'd probably almost make it as a statement. I don't think I have a solution. We definitely know that rurality is a risk factor for access to services. We do know that a lot of the phenomenon that everyone got excited about when lockdown in terms of delayed presentations is something we've always struggled with regionally, and that the burden of when to worry or not is carried. When I talk about that transactive memory, we're really stretching our memories and what everyone has to hold. So it's probably, I take it as a statement of absolute fact. What can we do to counter that? We should be doing everything we can to foster the decentralisation of specialty medicine and access, and that requires a workforce strategy 15 years in advance, unlike we're copying right now because of 15 years of neglect, but also utilising technology. So what could we practically do today? The two things I would say is if you don't feel you have a friend that you can phone, for instance, if I had a query injury today or I had a query jaundice today, who would I phone? And if you're ringing RCH, and is there someone more locally that you can introduce yourself to and test their access? And if it's through a public hospital, that should be one option. And then I think the other is certainly telehealth. And so a lot of what we can do, we can use the clinical knowledge of the people on the ground to provide those things like I've seen this child, the cranial shaped spine, their head circumference is here, this is their presentation, and you can have that telehealth consultation because you've fed in all the variables and you've got the clinical assessment on one side and the kind of the stored rabbit hole knowledge on the other and come up with something. I think that's the other solution for decreased access. It does mean we're spending a lot more time on the phone, but we understand that and we've still got to keep everyone safe.